evening. It's about to evening, half an hour left. 4:30 is already here. So, आप सभी का सबसे पहले तो बहुत बहुत स्वागत है on behalf of भगवान महावीर कैंसर हॉस्पिटल एंड रिसर्च सेंटर. आज हम लोग यहाँ पर मौजूद हैं एक बहुत ही खूबसूरत दिन सेलिब्रेट करने के लिए. As Bhagwan Mahavir Cancer Hospital and Research Center is celebrating their silver jubilee of their foundation day, and today we have very well experts from all over the India about the subject we are talking today. The program theme is Excellency with Speciality. Silver Jubilee celebration की अब हम यहाँ पर शुरुआत करते हैं. एंड जितने भी यहाँ पर लोग हैं, एंड आई एम श्योर कि आप एक इम्पॉर्टेंट डिस्कशन का आज हिस्सा बनने वाले हैं, और इस डिस्कशन के ज़रिए बहुत सी ऐसी चीज़ें हैं जिनके बारे में आपको नॉलेज मिलेगी, एंड आप अपने अपने कोर्सेज में, फील्ड में, जो भी आप कर रहे हैं मेडिकल क्षेत्र में, उसमें आपको काफ़ी हेल्प मिलने वाली है. सो आज जो सेशंस यहाँ पर रखे गए हैं, वन बाय वन सेशंस के लिए मैं लोगों को यहाँ पर इनवाइट करूँगा, डॉक्टर्स को यहाँ पर इनवाइट करूँगा, और पैनलिस्ट के उस डिस्कशन के ज़रिए आपको काफ़ी कुछ जानने को मिलेगा. तो सबसे पहले मैं चाहूँगा कि सिल्वर जुबली का मौका है, जश्न का मौका है भगवान महावीर कैंसर हॉस्पिटल एंड रिसर्च सेंटर का. तो अगर आप सभी लोगों की प्रेजेंस दो तालियों के साथ हो जाएगी तो हम सभी को बहुत अच्छा लगेगा. थैंक यू सो मच. All right, so let's start this beautiful day, and initially हम लोग यहाँ पर कुछ सेशंस का हिस्सा बनने वाले हैं, and later I hope आप सभी को मालूम है कि इनॉग्रल सेरेमनी के लिए हमारे बीच में ऑनरेबल वाइस प्रेसिडेंट ऑफ इंडिया वो भी होंगे, तो उनका समय भी तय है, तो तय समय पर वो यहाँ पर होंगे और हम सभी उनसे भी यहाँ पर आज मुखातिब होने वाले हैं. फिलहाल हम लोग सेशंस की यहाँ शुरुआत करने जा रहे हैं, और जो पहला सेशन यहाँ पर होने जा रहा है उसका टॉपिक, उसका सब्जेक्ट है क्वालिटी इन कैंसर मैनेजमेंट ब्लाइंड विदाउट डेटा. सो एक बहुत ही खूबसूरत यहाँ पर ये सेशन होने जा रहा है, क्वालिटी इन कैंसर मैनेजमेंट, और इसके लिए इस सेशन को चेयर करने के लिए आई रिक्वेस्ट प्रोफेसर गोविंद शर्मा, सीनियर प्रोफेसर एंड हेड डिपार्टमेंट ऑफ सर्जिकल ऑन्कोलॉजी, महात्मा गांधी मेडिकल कॉलेज एंड हॉस्पिटल, जयपुर. मैं चाहूँगा सर आ रहे हैं तो हम सभी उनका तालियों से यहाँ पर स्वागत करें. सर प्लीज टेक योर सीट. मैं मीनवाइल सर के बारे में आपको बताना भी चाहूँगा. ही इज एक्स सीनियर प्रोफेसर एंड हेड सर्जिकल ऑन्कोलॉजी एट एसएमएस मेडिकल कॉलेज जयपुर, मल्टीपल ट्रैवलिंग एंड यूआईसीसी फेलोशिप एट एमएसकेसीसी न्यूयॉर्क, most distinguished faculty award of SMS Medical College 2021, established surgical oncology department and started MCH course in surgical oncology at SMS Medical College Jaipur 2019, founder and secretary Rajasthan Cancer Society, ex-governing council member of Association of Surgeons of India. So there are many more points, बट फिलहाल के लिए सर यहाँ पर आ चुके हैं. सर आपका बहुत बहुत स्वागत. इसी कड़ी में आई रिक्वेस्ट डॉक्टर अजय बाफना सर. डॉक्टर अजय बाफना, एक बार जोरदार तालियां हो जाए सर के लिए भी. ट्रेन फ्रॉम टाटा मेमोरियल सेंटर मुंबई, मोर देन 23 years of expertise, more than 28 years of experience, joined BMCHRC in 1998 and established Department of Oncology, many national and international publications, research in acute and chronic ल्यूकेमिया, ब्रेस्ट कैंसर एंड मेनी मोर. सो अब मैं आप दोनों से रिक्वेस्ट करना चाहूँगा कि सर प्लीज़ प्रोसीड विद दिस सेशन, एंड जो स्पीकर हैं उनको आप यहाँ पर इंट्रोड्यूस करें और उन्हें भी अपने साथ यहाँ पर बुलाएं फॉर दिस सेशन. ओवर टू यू सर.
Good evening and welcome to all of you, and I really congratulate every one of you on the occasion of Silver Jubilee celebrations of Bhagwan Mahavir Cancer Hospital and Research Center. I really wonder how time flies, and for your information, 3 of the consultants sitting over here are also completing their 25 here today. Myself, Dr. Nidhi Patni and Dr. Sanjeev Patni. So it's a great opportunity for us also that for last 25 years we have been working with this institute, and I've seen the the journey of this hospital coming to such a high level. So in this session, we will be listening to Dr. Jayesh Shah. He is trained at Tata Memorial Hospital, Mumbai. He is a fellowship at MSKCC, New York, USA. And he has pioneered in laparoscopy and GI oncology in South Gujarat, and invited as operating faculty and guest speaker for national and international conferences, conducted many live surgical workshops for laparoscopic surgery in Surat, and won Best Laparoscopic Video Presentation Awards at various conferences. He is the Honorary Secretary of Lion Cancer Center, Surat. And I take this opportunity to inform you, all of you, that we are really missing Dr. P.B. Desai today because of he's not keeping well, so he couldn't come to attend this conferences. Dr. P.B. Desai has been associated with the BMCHRC from the day of its inception. And time to time, the advices given by him, you all have seen how BMCHRC has grown over the last 25 years. Why I'm mentioning his name? Because he's associated with the hospital for last more than 25 years. And Dr. Jayesh Shah, who is the speaker of today's session, he is the nephew of Dr. P.B. Desai. So I invite Dr. Jayesh Shah to deliver his oration. Dr. Shah, please.
Big round of applause, ladies and gentlemen, for Dr. Jayesh Shah.
And a very important introduction is, he is my hostel mate. We were together at Tata Hospital on the 10th floor. So welcome, Jayesh.
Thank you everyone, and good afternoon. I'm extremely happy to see my close friend Raj Govind after such a long time. And we have spent a good number of years together at Tata Hospital. First of all, at the outset, I would like to congratulate the Kothari Memorial Trust on completion of 25 years of this Bhagwan Mahavir Cancer Center. I think it's a proud day and a proud achievement for the hospital and for the trust. I'm extremely thankful to Dr. Gitanjali Agrawal, Medical Director of the hospital, for inviting me to be a part of this wonderful celebration. I'm going to just talk on a general talk on the cancer care, the scenario at present in India, and what we need to do to improve the care. Can I have the slides, please? How do you change, Raj, the slides, and how do you change that when it comes? No problem. Yeah, fine. I think it is a proud moment for everyone in this hospital, and I heard a lot about this institute. It's a huge institute. I wish that I also someday get an opportunity to come and be in the institute for a few days.
While we are getting the slides on, one more thing about Dr. Jayesh. He was the first person in Surat, and he has developed surgical oncology in Surat to a big extent. He first joined the Red Cross hospital there.
Lions Cancer.
Lions Cancer. And from scratch, he developed the facilities there in Surat and took them to national level, where today people can just walk in and get themselves treated. Another thing about this place, Bhagwan Mahavir Hospital, when we started off, I was on deputation to this place, and Dr. Desai used to frequently visit. He was so keen, and he used to make the maps and everything, and was a part of this right from the inception. And in between also, he used to come he was really a big help, and I wish him good health.
Yeah, he was very closely associated with the initiation and development of the whole institute. He would have been very happy to be here to see like where it has reached. And now that with passage of time, okay, so are we on? Yeah. Now how do we change the slides?
I will. You could just say next slide and then put.
Okay. Yeah, next slide, please. Next slide. I think it's going to be a bit difficult. Can we have the next slide? Yeah. There are almost 9.6 million deaths from cancer every year world over. Next, please. And the trend in India is no different. It is almost the same as in the global landscape. Next, please. Next slide. Yeah. Now, this is data which is a little few year old. We would have about 5.5 lakh deaths every year. This is about 6 to 7 years back. And it is almost the third leading cause of death in India, preceded only by cardiovascular disease and lung diseases. Next, please. But as of in 2020, we have had a huge jump in the incidence of cancer, almost 14 lakhs new cancer patients every year. And it is expected that by 2025, there will be another 12% rise, leading to almost 16 to 17 lakhs of cancer, new cancer patients every year. Can I have the next? Next, please. Yeah. Now, in these 14 lakhs new patients, the major burden is from the breast cancer, which is around 13%, and 10% from the oral cancers, and 9% from cervical cancer. But the biggest issue that is going to happen, it is expected that by 2040, the incidence might double than what it is now. So from 14, it might jump to somewhere around 25 to 28 lakhs. So we are going to see a huge burden of new cancer patients every year. Even today, the cancer patient population is somewhere around 27 to 28 lakhs. But the worrisome factor is there is every year a death of almost 8.5 lakhs patient from cancer, which was 5.5 lakhs about 6 to 7 years back. Next, please. Almost 47% of the cancer are from breast, oral cancers, cervical, lung, and colorectal cancers. Next, please. Now, it is estimated that 1 in every 20 male and 1 in every 24 female in India will be dying by the age of 75. They'll be dying from cancer diseases. Now, 25% of all cancer deaths in male are due to oral cancer, stomach and lung cancer, while 25% of death in females are from cervix, breast and oral cancers. Next, please. We know the biggest risk factors to be tobacco, both in form of smoking and non-smoking, that is chewing gutkhas. Alcohol again is a major factor. Pollution is cited to be another major factor to cause lung cancer. And in last few years, there has been a jump in fast food dietary habits, which has a very high calorie and very low fiber intake. So these are the factors which are leading to increase or rise in cancer incidence in our country. Next, please. So it is expected that 1 in 9 Indian, every 9 in 1 will develop cancer during their lifetime. Next, please. Now, 70% of all cancer deaths world over that occurs in low and middle income countries. And unfortunately, we are still bracketed in that developing or low income country. We hope that very soon we get moved out of this bracket and we come into the developing nation status. Next, please. Now, we need to pay respect to some of the stalwarts of cancer care in India. They have pioneered not only the cancer treatment, but they have also helped in establishing cancer care centers all around the country. Dr. P.B. Desai, sir, who has been closely associated with this institute, Dr. Jasawala, Dr. Rao, sir, all from the West Zone, Dr. N.C. Mishra, sir, from the North Zone, Dr. Shanta Madam in the South, Dr. Majumdar in the East Zone. These are all the stalwarts, and there are many more. It's difficult to name or write down everyone's name. So there are a lot of stalwarts who have really helped and pioneered in the cancer care in our country. Next, please. Now, the biggest issue in our country at present is there is a wide gap in cancer care between the rural and urban centers or rural and urban population. In the rural population, there is an issue of accessibility to a cancer care facility or for the diagnostic and treatment facility. And quite often they need to travel a great distance to get them diagnosed or get a treatment for cancer. The other issue is the affordability, because a large population in our country still falls into the middle or the low socioeconomic group. Next, please. Now, if you see here, there are about 180 cobalt machines in our country and around 365 linear accelerator machines. Next, please. So it is around somewhere 550 radiation centers all over the country. Now, as per the recommendation, we need at least 4 teletherapy machines per every 1 million. So that is per every 10 lakhs. Now, compared to that, what we need actually is around 5,000 machines in the whole country. So we are falling short almost by around anywhere between 4,000 to 4,500. Next, please. Now, unfortunately, a major cancer centers, which are really very well equipped, very well sophisticated, almost at par with the Western nation, but they are located mainly in Tier 1 and Tier 2 cities. And Tier 3 and 4 cities have very limited availability, but they have to cater to a large rural population. And so even with a limited facility, then they get overstretched in treating this patient. So we need to have more cancer care centers in Tier 3 and Tier 4 towns or cities, whatever you call them. Next. 30 years back, we would see that more than 30 or 40 years back, we have seen a lot of cancer centers being established by philanthropic donors, just like Bhagwan Mahavir Cancer Center, and similar even to Tata Cancer Hospital, which has been established by philanthropic donors. Some of the centers in our country have been established by some of the NGOs like Lions or Rotary, and a lot of them are partially aided by the government institutes. It is only in the last 15, 20 years that the corporate have really woken up and shifted their attention from cardiac diseases to cancer diseases. And we are seeing now more corporate or multi-specialty hospitals coming up, and especially with the CSR, that corporate social responsibility, where some of the major industrial houses are trying to establish cancer centers. But unfortunately, even at present, almost 80% of health expenditure occurs in the private sectors. And while cancer treatment needs to become a priority for the government of India, and we need to have more cancer centers to the tune of like what we had civil hospitals in the past, treating poor or low socioeconomic group patient for general diseases. On the same pattern, we should have more government cancer hospitals also. Next, please. Now, there are certain barriers of cancer care in our country. One is, as I said earlier, that there is a big rural and urban disparity. Large population in the rural area, but with a fewer number of treatment centers. And also socioeconomic factors because of the high diagnostic and treatment costs, which are difficult for low-income group to meet. Next, please. Now, fortunately, our Honorable Prime Minister, Shri Narendra Bhai Modi, initiated a scheme, Ayushman Bharat, in 2018, that is for Healthy India. Now, this has really set India on path to improve the healthcare for poor and needy. But the main function of these schemes are to finance the low socioeconomic or poor patients, and the patients can go and get treated at private or semi-private institutes. So basically this scheme is structured to fund the private health sector rather than investing more into the public health sector directly by the government. Next, please. There is also a shortage of skilled manpower, and we need more manpower, we need more centers so that we can reduce the treatment initiation time. Quite often we see that once a patient is diagnosed with cancer, and then by the time he or she goes onto the radiation machine, it's almost 3 to 4 weeks lag. And that's because of lesser number of centers and a higher patient burden on the centers. Next, please. Now, as per the National Cancer Grid, at present there are somewhere around 284 cancer hospitals in India. Now, if we come to the available skilled manpower, if you see there are 190 MCH surgical oncology seats and 80 DNB surgical oncology seats. And there might be somewhere equivalent number, same for the medical oncology, and little lesser number of seats for the radiation oncology. So effectively, let's say if there are 270 surgical oncologists every year coming out of the center, and we presume that all of them pass their exams, then still that 270 number is not big enough to meet the challenges of the oncoming patient burden that is going to happen in next 8 to 10 years. Next, please. And even out of all these who pass, there are not enough centers where they can be absorbed as a junior consultant or consultant. So what happens is that instead of settling down in a smaller places where there are small cancer centers, they end up settling down in a tier 1 or tier 2 city as a private practitioners. So almost 60% of patients get treated at individual level at individual medical consultants, whether surgical or medical oncologists. So effectively, it becomes difficult for the patients to undergo multidisciplinary team approach, which is now the scheme of the thing where all the patients new patients should be decided by a multidisciplinary team approach for the treatment policy in future. So multidisciplinary team approach is feasible mainly in the secondary or tertiary center, where again, it becomes difficult because of the heavy workload. Next, please. A major step in trying to deliver a high quality cancer care in our country was setting up of National Cancer Grid, which was set up in 2012. And this is a consortium of almost 230. Now I think it is somewhere around 250 centers on the NCG. They function as a platform for exchange of evidence and expertise, producing evidence-based management guidelines specifically in the Indian scenario, Indian setup, and for the Indian population. Next, please. So what we need to ask today is, are all the guidelines emerging from the West good for us? Let's see an example for oral cancer where large number of patients who are tobacco chewing or gutka chewers, they have severe SMF, less than 1 finger mouth opening. You operate them, is a T3 or T4 oral cancer, and then you need to send them for post-operative radiation therapy as per the NCCN guidelines. Now, what will happen? By the time they finish their radiation therapy and within a month, they will have almost a lockjaw. So it's difficult for you to even access in follow-up in future whether they are going to have a recurrence or not. So can we do something different? Can we substitute radiation with chemotherapy? These are all the answers we need to get from our own trials. And similarly, from T3 or N-positive esophageal cancer, where now neoadjuvant radiation therapy has come into vogue that you need to give neoadjuvant radiation before you operate to decrease the rate of local recurrence. But most of our patient population are heavy BD smokers. They have COPD, they have fibrosis, they might be having a underlying tuberculosis infection in the past, which has also increased their fibrosis. So though the newer radiation machines give you less of a morbidity, but still there is an issue with increasing fibrosis in this type of patients, and it becomes difficult during surgery and might increase the morbidity. So can we do something else? And can you substitute neoadjuvant radiation with chemotherapy? These are all things we can address when we have our own trials in our own country, large trials, and then we can shift our treatment policy rather than following purely what the West advises. Next, please. The Another major issue in our country patient population is a social stigma for cancer. So large number of time, females having breast lump or breast malignancy, they don't end up visiting their consultant till the tumor becomes quite late, almost T3 or T4. Even if when they are diagnosed early, they might try to avoid treatment so that people in the society wouldn't come to know that she has a cancer, thinking that it might hamper the marriage outcomes for the children. So there are a lot of other issues also in the country compared to the Western patients. We need to have more screening facilities available in the country so that we can pick them up early. Next. The other issue is of the proper reporting. As of now, we say somewhere around 14 lakhs new cancer patients were seen in 2020. Fair possibility that the number might be still higher because a lot of cancer patients get treated in a private individual setup and they may not be registered anywhere. So next please. So we need to have a proper cancer registry which can be updated properly. Each and every cancer patient needs to be registered. Then and then we can be very sure about what is our data of the incidence and the mortality. And unfortunately, cancer is still not a notifiable disease. But I presume I read somewhere about a few weeks back that government is going to make cancer as a notifiable disease. And then probably each and every new cancer patient will get registered and we'll have a correct data from our own source. Next, please. The same thing is with the cancer mortality rate. Quite often, advanced cancer patients die at home. The family physician might just give a certificate. The patient died of natural cause. So we don't know what is a natural cause. Next, please. So what should be our goal? Our goal is early detection and treatment implementation, which should be equivalent whether you are rich or poor, whether you are in a rural setup or an urban setup. The patients in the rural setup also deserve the same quality care as people in the urban setup. And we need to diagnose quite early with establishment of more detection centers. Next, please. Now, we don't need to go overboard in trying to detect early cancer or trying to get the best result in our patient population. So we don't need to go overboard by doing mammogram for every young individual that we see because it may not benefit in dense breast. Also, we see a lot of new patients who come. They are now very Google smart. So they even in T1 tumor or breast tumor, which is 1 centimeter or less, they still want to get a PET scan done. So these are the things which we need to dissuade them from getting it. Also, we need to be very sure about how we are treating our advanced cancer patients. We don't want them to spend more, especially when the survival outcome is not going to be great. So we have to be mindful of the out-of-pocket expense for the patients because everything cannot be covered even in any yojnas. So yojnas don't cover microvascular surgeries, they don't cover the target therapies. So just to play on the emotional factor of the patient's relatives and keep on treating with expensive drugs is not a thing to be done at all. Next, please. So the key issues are get the proper quality care, reduce the risk by making more people aware, and take an early consultation and treatment, and hopefully, the government makes cancer a notifiable disease, then we can get the correct scenario, what is going on in our country. Next, please. The other issue, as I said, was manpower infrastructure shortage, which is Achilles heel of our cancer pathway in India. And hopefully, in next 10 to 15 years, we might be able to overcome that by getting more cancer centers, more skilled workers to take care of the expected higher number of the cancer incidents that is going to happen in next 10 to 15 years. Next, please. Now, in 2016, India was ranked 145th out of 195 countries as far as in healthcare access and quality index. Hopefully, we should try and make effort that we go somewhere around 70, rank 70 at least in next 15 to 20 years. So That should be our aim. So to conclude, we have to target our efforts for prevention, for early diagnosis, and that we detect them early and give a proper equitable treatment for all, whether they are urban or rural based, rich or poor, irrespective of class and creed. Thank you.
Thank you, Dr. Shah, for your valuable inputs about the cancer care. And this was the part of session 1. And I request, if you want to say something, sir, please.
Yeah, wonderful talk, Dr. Jayesh. Dr. Jayesh has touched upon the most important aspects in cancer care and where we stand today in the country. He talked about the common cancers, most of them which are preventable. India has oral cancer, breast cancer, cervix cancer. Most of them can be detected early and prevented. He talked about the gaps in the facilities, the rural-urban divide, the clustering of trained manpower in the metros. Then he talked about the public should get into it with the social responsibility, the corporate social responsibility. We don't have to look at the government only to do it. Now people are coming, even Tata Hospital is now making centers all over the country. Recently in Chandigarh, near Chandigarh, TMH has started a center. And let me tell you, Modi ji has done a wonderful job by this Ayushman Bharat. But Rajasthan is different. Rajasthan is catering to the people not even who are below the poverty line, but to everybody. Today, anybody and everybody can take a Chiranjeevi card and they will be covered up to 10 lakhs. So this is a change that we have seen recently. And today, previously what used to happen was people did not take treatment because of financial issues. Today that thing has been taken care of. So now what is the other thing which is coming in? The other thing is the social problem. We need to have our own guidelines. The West says do breast conservation surgery in everybody. But here we have to see the social fabric. If we advise a breast conservation surgery, 90% of the people on the table say, no, you do a mastectomy. Reasons are not very, very difficult to understand. The reasons are mother-in-law, husband, the children going to school. The female thinks that supposing she has to have radiotherapy after breast conservation surgery, she'll have to stay 1.5 months near the hospital. The husband will be off work. The children will be off school. So it is the social fabric. Just to give you an example, that in the army, the acceptability of BCS is very, very high, more than 50%. Reason being, if the female has malignancy, the husband is transferred to that place, and then the treatment is taken care of. Then the female says, yes, why not? So it is more of a social problem rather than anything else. He very well talked about, can we do something else? Dr. Badwe has done something else. There is a common myth. People say, if you touch the tumor, it will spread. Everybody, almost all patients say. What Dr. Badwe did was, he took this clue and he started injecting xylocaine, local anesthetic, before the surgery. And that has shown to radically increase the survival. What happens, it's a difficult situation to understand, but you have to think out of the box. He again discovered this thing about the menstrual cycle. Operation in one phase of the menstrual cycle leads to better survival. And probably somebody is going to come out next with operating in the day or night. If the moon can move the oceans, probably it must be having some effect on the human body. So there are figures, understanding which needs to come. Then he talked about cancer registry. Let me tell you, Dr. Kabra is here. He is a pioneer in cancer registration. He did a lot of work in that. And it is a notifiable disease. But still, it needs a political will. We could do it in COVID. Anywhere in the country, if COVID was, or the world, COVID was discovered, it was reported. Why can't we do it for cancer? We'll have so much of data available. And then rightly he said, when cars can have a pollution check and insurance, why can't human beings have a regular checkup? So Jayesh, thank you very much. Wonderful talk.
Thank you so much, sir. To proceed with the second part of this session, but before that, I request our Executive Director, sir, to come up on stage. Parikh, sir, I request you to please come up. Sir, please be with us on stage for a few more seconds. And we would like to give a memento to all the members on the stage. So first of all, I request Dr. Parikh, sir, please आप अजय बाफना सर को यहाँ पर मोमेंटो भेंट करके उन्हें थैंक यू कहें. इसी कड़ी में प्रोफेसर राज गोविंद शर्मा सर को भी हम मोमेंटो भेंट करके उन्हें थैंक यू कहें. And now to our speaker, special speaker, Dr. Jayesh R. Shah, specially came from Surat, Gujarat, to deliver his session and presentation. Thank you so much, sir, for being with us in this beautiful and important session. Thank you.